Thanks, Helen. Yes, I stepped in for Adam, who unfortunately couldn't be with us today, but very much wanted to be here. Um, yes, it's jam-packed, so let's get started. I've hit record, and I'll edit this for YouTube, but let's get started. So let's do digital, one of our quarterly meetings. Our second one now is a spin-off from the Let's Talk Digital conference, and we're doing it again next year. I think we're going to do it every year. It's been a really big hit. We've had 102 people registered to join us, so hopefully they'll be joining us in the next few minutes, but I'm going to kick off anyway. So we've got Joe Chambers, who's going to kick off with the first talk. Then we've got Paul Atkinson and Tracy Miles. Now, Joe is a fantastic lady. I just think she's doing some amazing stuff. She is a patient advocate, and her bio reads like this. She is a breast cancer patient and a patient advocate for both SWAG and NHS England in a range of roles. Her main interests are personalised care and innovation. In her personal life, she is an engineer with 15 years experience. Her background is in electronics, but has recently completed an MSc in biomedical engineering as a direct result of being a patient and sitting in waiting rooms wondering why things are designed the way they are, often not taking into account patients' experience. In between cancer treatment, she is working towards qualifying as a clinical engineer in the NHS. Being both a patient and an engineer gives her a unique view of both sides when it comes to digital innovation, and she's going to be talking more about this. So I'm just going to share her slides. If Joe, you could unmute yourself, we can get things going. And just say when you want me to move the slides.
Okay, perfect. Thanks, Mark. Yeah, so I'm Joe. I'm a cancer patient, and as Mark said, I I'm an engineer as well, so I kind of seen things from both sides. So hopefully, what I'm going to try and do is share a few different things from what I've seen both as a patient and both as an engineer. Next slide, please. Okay, so to put in place a good digital system, you need to put the patient at the heart of it. If you don't, you can design the best system in the world, but it'll be useless. So what does a patient look like from a digital perspective? Next slide, please. So the average reading age in the UK is 9 years old. 40% of adults struggle to understand health content. 60% struggle with numbers and statistics. 43% don't have a computing device. 16% don't own a smartphone. 6% of homes in the UK, and that's around 1.5 million, don't have internet access. So often people have this sort of throwaway comment of, oh, my parents or grandparents are really confident with technology, so everyone must be. But it's such a poor assumption to make, because some people lack the skills and confidence, others lack the access. And with the cost of living crisis, this gap in access is only going to get worse when your choice is between affording to eat or heat the house. Wi-Fi access for healthcare is not something that's going to be a high priority. And during the lockdowns, there were stories of people having to go to places like supermarkets to access free Wi-Fi as libraries and community centres were shut down. The digital divide is a much bigger problem than many people realise. Next slide, please. But as with any statistic, you can flip them around. So 99% of adults aged over 16 who have internet access choose to use it. 94% of households do have internet access, and 84% of adults do own a smartphone. So there is a digital divide, but there are equally a lot of digital enabled patients out there too. Next slide, please. So what? Well, what that all means is that there is no one size fits all solution. Digital will never be the complete answer to a question that involves something that's patient facing. Those less likely to have digital access or skills are often those who need healthcare access the most, over 65s and those on low incomes. You also need to consider people with disabilities that make it more difficult to access digital services, such as loss of sight, loss of limbs or paralysis, and even some side effects of chemo. I have palmar-plantar syndrome from my chemo, and with the skin literally peeling off my hands, it can be really difficult to use a touchscreen at times, which is pretty frustrating. So there is no one size fits all. And where you're employing a patient-facing digital solution, you always have to think about giving patients a choice of how much they want in a digital format. Some will want everything, some only parts, and some will want nothing digital. You always have to consider all patients, otherwise you'll be excluding those that aren't able to access digital. Why should they not be entitled to the same level of access to healthcare and support as those that are digitally enabled, just because it might be easier to just have one digital solution rather than multiple solutions? Next slide, please. What about clinicians? Are you ready for digitally enabled patients? How many virtual appointments, and by that I don't mean phone appointments, are actually taking place? I rarely hear about patients being offered them. I was offered one once, but actively encouraged to go to face-to-face or phone. Who's making that choice? Do patients not want it, or do clinicians not feel comfortable using it as a format? Do clinicians have the range of communication skills needed to communicate using digital? This is completely different to the traditional face-to-face consultations. Are you giving patients enough information to be able to access service digitally? There's so much out there digitally in terms of services and support, but I found almost everything by accident through doing Google searches and from peer support groups. Do you as clinicians know what's out there and how to access it? Do you have the capacity to deal with an increase in patient queries, perhaps through improved access to be able to ask questions digitally? Do you know how to deal with data from apps? There are some really great symptom tracking apps out there, for example. Do you know how to use or access that data your patient has carefully been recording over the last chemo cycle? Some of it can be really useful to track severity of side effects over time, but it's completely useless data if a clinician either isn't interested in it or doesn't know what to do with it. And are you able to keep up with developments quickly enough to keep up with your patients? For example, with many conferences being online, I can access as a patient the data being presented live. It's often shared on platforms like Twitter as developments happen. I have access to research papers online and also treatment protocols and trial information. I'm not an expert, but I've learned enough about my cancer to be able to understand a good amount of what is available to you as a clinician, and I actively read it as I want to know as much as I can about my options. And that availability of information has greatly increased during COVID as everything went digital and virtual. Can you keep up? Do you make sure patients are accessing safe and relevant information rather than randomly consulting Dr. Google? Next slide, please. What about the wider system? Does staff have the skills and knowledge ranging from use of basic IT through to an understanding of advanced techniques such as artificial intelligence? Are your digital systems safe? Do they meet the relevant regulations and standards? Do you know what counts as a clinical device and what needs to meet which regulations? For example, an Excel spreadsheet being used to calculate the dosage of a drug. Is it safe? Is that a device helping you make a clinical decision? Are any apps you're using or recommending appropriately approved? And what about data protection? Many systems that use AI for radiology, for example, want to have the images sent to a central server off-site to be analysed. Is there a robust system in place to ensure those images are anonymous? And what are your verification and validation processes, both before you start using something to make sure it works as it should, but also throughout its life cycle to ensure it's still working as it should? We all know we can never trust IT. How much are you actually checking things are still working as you design them? What about joined up systems? Is information shared between hospital departments effectively for patients with comorbidities? What about information sharing about patients who are on a pathway shared between two different hospitals? What about primary and secondary care? As a patient, I spend a large amount of time having to repeat information and often update different specialists on what's happening as they don't have the right information, as either it's not joined up or so slow that the information flow can't keep up with my appointments that might even be a week or two apart. Next slide, please. So when it comes to identifying what the user need is, ask what are the problems that need solving, not, oh, I've got this thing, how can we use it? Digital will only ever be part of the solution for patients. What is the other part and who's doing it? And don't make assumptions. Do the groundwork properly and understand the need before you start. And I'll give an example of this based on a statement I've heard said about remote monitoring systems. Next slide, please. And that statement is, patients should have access to their results. Now, I think this is actually quite a good thing. I think patients should have access to their results, but has it been properly thought about? And I'm going to pull this statement apart. Next slide, please. And we'll start with the word patient. Patient means everyone. As I've already said, not every patient is digitally enabled. So yes, there is absolutely a digital solution to this statement. But what about those that can't access digital? Do they not deserve equal access to their results? Also, why only patients? Should primary care not have access to the results at the same time? As I said, often I'm having to go in and tell my GP my results myself before I can then have an informed conversation because my results haven't made it to primary care before I actually go in and see my GP. Next slide, please. What about the word should? It's actually quite a strong word. Why should patients have access to the results? Who's actually asked patients whether they want access or not? And what cross-section of patients were asked? There is no one-size-fits-all answer to this. Has anyone thought about the psychological implications of allowing patients access to their results, particularly if they were able to access them before having them explained by a clinician? Next slide, please. What do you mean by access? Do you mean patients are able to view their results physically on a screen? Or do you mean that the results are accessible, as in understandable to patients? Are you expecting every patient to be able to understand the acronyms of a blood test or the technical language used in a CT report? They're not written in plain English. So is releasing this level of technical information actually useful? Are you intending to write a patient-friendly version of these results that are being released? And I suspect the answer to that is no. And what about patients who don't have English as their first language? How are they going to understand it? And in what time frame is access being granted? As soon as they're ready, so it may well be the patient seeing this before the consultant. Is that a good thing, especially if it's bad news? Are they released after seeing the consultant, so the results are talked through with opportunities to ask questions and then available to be reviewed by the patient after? And is this all or nothing? For example, I would really like to see my pre-chemo bloods as soon as they're ready so that I know whether my next cycle will be going ahead, rather than having to wait potentially to find out when you're already sat in the chemo unit. Whereas I really don't want to see any CT scan reports until my consultant has sat and gone through them with me. That's my personal preference. Does the access arrangement allow that? Don't ask me to just choose what I look at. If there are results available, it's like saying to someone, don't press that big red button. You can't help it. And everyone will have a different preference over what they want to see and at what point. And meeting that preference has a big impact psychologically. Positively if you get it right, negatively if you get it wrong. Next slide, please. And what results are we talking about? Bloods, scans, pathology, post-surgery, clinic letters? And again, in what language? Technical clinical language, i.e. exactly what the clinician gets. I'm not a clinician, so how am I expected to interpret these results correctly? Particularly in oncology, when often as a patient, you will interpret things more negatively than they might actually be, just because you don't understand the language caused, which might just cause unnecessary anxiety and then a panicked phone call into the team to get answers rather than being able to wait for the next appointment. Next slide, please. So as you can see, it's so important to not make assumptions. You need to understand the need before you start. Look at what the problems actually need solving are and design based on that, not trying to bring something in and make it fit when it doesn't quite have the right functionality you need. And really importantly, talk to patients, and that's right from the start. So right when you're designing the strategy, that's right from the start of a project and all the way through. Don't just come to us at the end and go, oh, can you review this? Because by that point, it's too late to make any changes. Get patients in and get them involved and co-produce, because that's how you make sure that what you're designing is right for what patients really need. Next slide, please. So what do patients want? Well, here are a few of my thoughts. Even as an engineer who understands the art of the possible, in terms of what digital can do, what I want as a patient right now is the basics done properly. Up-to-date, accurate information on trust websites. Signposting to services or resources to help self-management. Space for my preferred name on my digital notes, because my preferred name is different to my full name. Digital appointment letters, so I don't have this big stack of paperwork that I can never find the right letter in. And surely even if a quarter of people wanted digital appointment letters, that would save a huge amount in printing and paper and postage. The ability to change your appointment time online. Better ways to communicate with admin teams for non-urgent queries and out of hours. I can't always phone people back when they leave me a message during the working day if I'm working, and then there's no way of getting that message in. So why can't we have a digital way of sharing those non-urgent questions back to admin so that they can answer it when they're back in working hours? Joined up sharing of information digitally between primary and secondary care and between trusts for shared pathways, and digital consent forms. You've then got things like improving clinical care, matching patients to suitable trials. This is something that could be done digitally much more effectively, where you have this database of open trials and at which trusts they're being done, along with the eligibility criteria, and a digital system then pulling out basic information from a patient record and coming up with a list of possible trials, suitable trials for every individual patient. What about an automated alert for the referring clinician when scan results are back, rather than them or the CNS having to trawl through records repeatedly when they're waiting for an urgent scan to be reported? What about space on my notes for personalised care aspects of what matters to me? So clinicians can make notes about things like the fact, for me, I like being really active and up in the mountains and canoeing, and also I live alone, so I have limited support. These aspects don't really fit into the normal clinical bits of the electronic patient record, but they're really, really important to actually aid clinical decisions and make personalised care actually personalised. Why can't we have a space on my notes for that? And what about solutions to help with manpower shortages to speed up the time it takes to get results? Pushing through things like AI to support radiologists, making sure it's good enough to actually be used. And what about solutions to help pathology? And most important, patients want and need choice in how to access. There is no one size fits all. We're all different in how we need to access healthcare. Next slide, please. And so as an engineer, how do you make digital happen? Well, a couple of thoughts. Firstly, again, identify the need. Have a really clear strategic direction. Remember that patient-facing digital systems aren't always the only solution. How are you providing the same capability to those that aren't digitally enabled? Digital will only ever be part of the solution. Don't work in stovepipes. I see this so much and it frustrates me so much. Communicate with each other, work together. Why is everyone reinventing the wheel? Everyone's trying to do the same thing. And forums like this are amazing to be able to share the information and just get people working together towards the same aim. Consider everything before you start. Things like equipment. Have you got enough computers for everyone to log on to, for example? Training, and that's for both patients and clinicians. Interoperability. Don't bring in another standalone system. So many times I see my consultant just trying to log on to like 4 or 5 different systems just to be able to have one appointment with me. Make sure everything's interoperable with everything else. Test and acceptance. How do you know it's doing what it should before you start, and also all the way through? How do you continually make sure that it's still doing what it should be doing? Safety and data protection, and always don't forget the soft aspects such as the psychological impact of using digital. And involve all stakeholders right from the start. Don't forget to involve patients. If you want to know what patients need, you've got to involve us. And also a bit of a plug for engineers, as I am an engineer. We are much more than just fixing broken equipment. We understand procurement, we understand systems engineering, we think outside the box. Come and have a chat to us. We also understand the regulation side of things. We can help. Don't forget us. We're here to help you. Next slide, please. So in summary, put the patient at the heart of what you do. You can have the best system in the world, but if it's not accessible, and accessible means a lot of different things, if it's not accessible to patients, then it's completely useless. Take a step back and look at the whole system from every perspective right from the start, and don't make assumptions. Otherwise, you'll miss something important that's difficult, impossible, or costly to design in at a late stage, and it will mean the system never achieves its full potential. Thanks, Mark. That's it.
Thank you very much for that, Joe. That was an amazing talk, and I think it's so powerful to have the patient's view here. We'll take questions at the end. Now, I think everyone's here has heard about the expert patient. What I like to brand Joe and Rob, who are digitally enabled, and the patients are digital expert patients, and it's amazing to have them on board showing us the way, because we are at the end of the day building this for patients. Of course, we need to try and improve our workloads and workflows, but it's amazing to have this story from here. And this does segue into our next presentation with Paul. So Paul's topic's changed a bit. I'll let him explain that himself, but a quick bio regarding Paul. So he's been a practicing doctor for the last 19 years and graduated from the University of Cambridge in 2003, made a GP partner in 2009, honorary clinical and commissioning champion for the Royal College of GPs in 2010, urgent care lead for Amber Valley in South Dales locality in 2011. He's been busy and there's more to come. Member of the British Computer Society in 2014, clinical advisor for NHS Digital in 2017, digital clinical champion for NHS X in 2016, founding fellow of the Faculty of Clinical Informatics in 2017. This is news to me, and I'm very happy that you built the faculty, because I'm a member of that as well, and hopefully moving the digital agenda and health forwards with the whole faculty. I think they are, I shouldn't say I hope. He's also, just like Rob, finished his master's from the Digital Academy. He is chair of the Royal College of GPs Health Informatics Group, and this is his current roles. He was just the CCIO for Gloucestershire CCG in 2017, but that transition, as you all know, to the ICS in July of this year. Now he's the CCIO and Digital Director of Gloucestershire Integrated Care Board, and I'm going to hand things over to him now for his talk.
Thank you, Mark, and I think it's excellent assembly of the session today, that actually a lot of what Joe was just talking about in her excellent talk, actually some of that I think I might answer in this talk, but in that slightly maybe first generation, slightly crude, slightly sledgehammer way, there's definitely more maturity, more nuance that could come. So I was hoping to come and talk to you today about Gloucestershire's digital strategy. Unfortunately, it is still going through ratification within the various organisations. So instead, I'm going to talk to you about something else that's been taking up a lot of my time, and which is a national policy about enabling access to the full GP record for citizens by default. So this isn't
Paul, just
new.
to let you know, I've got control of your slides.
I saw. That's brilliant. Thank you, Mark. So this is not new. This has been going along for quite some time. And I think Mark mentioned one of my previous roles. I was working with NHS England, and they became NHSX as part of the team promoting this. So for a long time, patients have had access to their GP records by a nature of an opt-in option, but it's still quite slow and not the sort of numbers that we would like. And then an intervention happened, and that intervention was COVID. And so as a result of COVID and of the COVID pass, we saw numbers of people who have access to the NHS app have grown significantly. And I think if I have the right stats, it's circa 30 million people now have got access to the NHS app. And so one of the things we're looking at is, well, what can we do with that? So one of the decisions that have been made is to move from a position of an opt-in process, a little bit like we did with organ donation, to a opt-out process. So from the 1st of November, all citizens whose GP practice uses one of the clinical systems that is ready, which is the two largest ones, will get access to their GP record and any new entries added from the 1st of November going forwards. If you've already got access, that access will still be there. But what this starts to do is it starts to really shift the default. And we've talked for a long time about phrases like no decision about me without me, and digital by default and things. And I recognise Joe's comment that she made repeatedly that digital is not for everybody. But one of the things I've often said when I've been talking to colleagues is actually, if digital is for some, if that means for some patients, they can then get their letters digitally via the national app, that's some trees we can stop chopping down, and some stamps that we can save, and some money we can spend elsewhere. So by making this a default position, it is a massive enabler for those who want to take a digital option. Not only will they be able to see all of their letters that their GP has written, but any letters that the GP have received will become available. Any blood tests that have been done or scans, if they've been requested by the general practice, will be available to the patient. So this enables a much more richer enablement of this sort of co-created care plans. There's old evidence that says by the time you've left my consulting room, within about 5 minutes, we're doing well if you remembered 3 of the sentences. So actually being able to go back and look at what I wrote and say that we discussed that you would lose weight and try to stop smoking, and I would increase your blood pressure tablets, and I would refer you to that. We can now have that written record and that co-corroborated, co-created care plan. So I think it's going to do an awful lot in terms of patient engagement with their care, and patient interest with their care. If we jump ahead, Mark, because I think some of these slides are from a deck to professionals. Yeah, so the slide you're on now is quite a good slide. So this is just showing what's been historically available. So medications, allergies, people have ordered therapy prescriptions for possibly since 2014, depending upon your surgery, and then some of the more technical coded information was available on request from 2015. But what's coming forward now is not just going to be that sort of technical language and left anterior myocardial infarction, but actually we'll be able to see what's called the free text. So we'll be able to see some of the descriptive writing around that diagnosis, and what that means, or some of the descriptions around that. And actually one of the things we've found where this has been done elsewhere is actually one of the side benefits is the corrections of errors. And so they think about 10% of medical records have got errors in, and that might be that we removed the left kidney, but actually, the records say the right. It could be something as significant as that. It could be that actually we think you had an allergy to an antibiotic, but actually it wasn't. It was a side effect or something else that was going on. So if this allows us to make the records more accurate, more complete, then that surely has to be a good thing. If we could skip forward to, I think I've sent you the wrong slide deck, Mark, sorry. I'll send the other one and we can forward it on later. Skip to slide 12, I think. We'll just say about some of the information that has been made available, both to clinicians, but also there's information being made available outside of primary care. So it's going to go into the hospitals, to the mental health trusts, to the cancer services, to think about the opportunities this change makes. There is also some information coming out to people about thinking when this isn't suitable. And so recognizing that this talk is part supported by the Cancer Alliance. So one of the things we're talking about is actually, what happens about information that you might want to share with the GP now that the patient hasn't yet seen. So most of the MDTs, the multidisciplinary teams that I know of, will send a summary of the meeting to the general practitioner within 24 hours. And so we want to say, well, actually, that's fine, but that record needs to remain hidden for the time being until the patient's had the opportunity to have that conversation with a trusted professional, so that they know when they can give it to them in the right context. They can discuss if there is bad news, discuss the plan, and it's not there. But there is something I think Mark talked about the expert patients. We know that Joe and Rob, etc. They only have one disease mostly to think about, so they will know more than I ever can about their one particular illness, and even compared to some of our specialists, because they will still have a section to discover and to know and keep on top of the education. But you can really delve down into your own illness, and of course, who's got more interest in making sure you get the right decisions? The patient is definitely front and center. So being able to allow them to review, and Joe made a point, I think, about whether or not people can understand the technical language and whether we need to rewrite these reports. My experience is that actually patients want the raw, unfiltered. They want to see the full thing, and they may well ask questions, or they may well go do some research. But the transparency of saying, actually, I've shown you everything. There's nothing behind my back. You're fully involved. You're fully engaged. I think is very powerful.
Thank you very much for that presentation. I look forward to the questions we'll have at the end for all three of you. Now, Tracy's going to be talking to us about breast cancer genes and me. Her bio reads as such. Tracy's nursing career spans 4 decades, though she doesn't look it. She has been working in medical, surgical, ITU nurse, working in UK and overseas. For the last 2 decades, she's led the gynae oncology nursing service in Bath, moving to a new role as Associate Director of Nursing and Midwifery in the Southwest Genomic Service Alliance. Tracy has published in Medical and Nursing Press. She is a Cochrane author and reviewer. Her doctoral and postdoc work looked at radiotherapy toxicity for gynecology oncology patients. Tracy sits on the parliamentary committees on women's health, is a NICE specialist committee member on a number of topics. She also is a nurse consultant for the Eve Appeal Gynae Cancer Research Charity, and somehow around all of that found time to come and talk to us today. Tracy, the floor is yours.
Cheers, thanks, Mark. And full disclosure, Tracy is practically a digital native, which is why I was delighted when Mark said he would do the Chris Whitty thing and change the slides for me, because I knew I'd cock it up otherwise. So yeah, breast cancer genes and me. So I'm not a breast cancer nurse. I was a gynae oncology nurse. So we'll go into the next slide, and this will describe why I am doing a project which is around breast cancer at the moment, because it's fallen out of a transformation program that we're doing in the Genomic Medicine Service Alliance in the Southwest, and it will roll out to all of you across the country. It's about to happen in about a month's time, so please keep your eyes and ears out for it, for those of you that it's relevant for in your various regions. And as you can see here, the idea is to enable our patients who are diagnosed with a gynae or a breast cancer. We don't forget prostate or pancreas either, for those of you who think that I've missed that. We do know, and we do need to cover that at some point. But the idea is that we actually enable our patients and clinicians to know a lot more about how we can support and possibly treat patients, knowing what their BRCA status is. So next slide, if I may, please, Mark. Out of this project fell this project, Breast Cancer Genes and Me. I'm loving this digital patient empowerment project, and that's exactly what it is, what it says on the can. So we are working with, I got a substantial grant from AstraZeneca, from the diagnostic side, not the pharma side. We're working with Southwest GMSA, which is who I work for, with the lovely Helen Winter and all of the oncology teams, and importantly with patient and public, and my secret weapon, well, you've heard from her already, she's called Jo Chambers. What we're doing is we are working with software providers. You will probably look at those logos and go, oh yeah, I know them. So do I now. I'm starting to learn their jargon, I know how to say open source now. Mark taught me what that meant. I was scratching my beard the last time I was on this. But what the idea is basically we are creating an animation, a digital animation that Jo, lovely Jo, who you met earlier, has helped to write the script for. And it's to inform patients what BRCA genes, and not just BRCA genes, other breast cancer genes, what having a test done, what that means to them, and what it can mean clinical implications wise. It's a bit like, I guess, having a patient information sheet, but in animation. The beauty of the animation means that it's easier to change it and update it. It's easier to put the different languages underneath it. It's also easier to colour the patient, whatever colour your patient is in front of you. So you can really make it bespoke for your patient group, which is brilliant. And as a multidisciplinary team, we put together a script. Jo, just to let you know, had a great time with the creative team yesterday, and the first rushes, I love all this jargon, I'm now into creative filmmaking, will be ready, and we will be looking at it all together, and then we'll share it with you. So that's only part of the project. The other thing is to get a platform right so that we can counsel and consent our patients, those that it works for, because as Jo has said, has identified, it doesn't fit for everybody. But those that it will work for, we will counsel and consent online for them. Sort of like the doctor, nurse, clinician will Zoom you there. The story that you've all learned through COVID, which is where all this came from. So next slide, please, Mark. The idea came from, and my engagement basically with the digital world was for the same reason that of all of us that weren't nerdy and weren't into it before, COVID. Where was I? I was at home at my kitchen table. Where was the patient? At home at her kitchen table. What did we want to do? Talk to each other. Did I need to physically examine her? No. What did we want to do? Talk to each other. Wouldn't it be nice to see each other? Well, why don't we do a Teams thing? Is that difficult? Boy, yeah. It's really difficult when back in the day when I was a gynae cancer nurse, only a year or so ago. Really difficult if the patient hasn't got a laptop, device is the word now. I'm getting it now, Mark. A device, a phone, a laptop, a tablet. What if they haven't got that? What if they've got that and they don't know how to use it? What if they've been given one of those, but they don't have the internet? So I learned about these dongly doodah things. So all of those things put together with Macmillan, the great green beast of the cancer world, who are fantastic when it comes to helping with patient support, put all those people together, including the patient, because as Jo said, if you don't listen to the patient, you'll get it wrong, and you will get it wrong. So listen to Jo and the patient. And what we did is we started what was called a digital inclusion project. And we did surveys. It was all around gynae. Here's some of the gynae team that you can see here that took the project on after me. And we basically went out to patients and said, would you like to have a go at talking to us digitally? Too right, they said. So we got a grant from Macmillan. We surveyed patients as to how they would like to learn, what they would like to learn, who had a device, who didn't, who had internet, who didn't. And what we have done basically in a nutshell is created a library of devices that we can lend out so that we can have the digital conversation with the patient and then they give it back after the end of their treatment journey. That sounds really easy. Of course, it's minus really easy. And one of the funniest things, well, actually it wasn't funny, I got annoyed, but there was a funny end to it, was talking to an IT person who wasn't in Bath. I'm not going to tell you where it was. Who just said, well, why on earth should an IT department be helping to loan out devices to a patient? And I went, well, put it this way. Somebody has a hip replacement and they get sent home with a Zimmer frame until they can walk again properly. What's different about sending somebody home with a device so that they can communicate with the doctor, the nurse, or the healthcare professional that they want to, and then give it back afterward? Simples. So they shut up after that. Anyway, so that's kind of what we're doing. There's the Breast Cancer Genes Project, the Digital Empowerment Project that Joe and I and other team members are doing. Macmillan, I know, are going to roll out more of this project that we started in Bath, because it's got to happen across the country, we feel. And then I've got 3 more slides just to show you. They're not mine, but they came from a meeting that I went to. And this is what I'm hearing from nurses, that things that are happening. So if you wouldn't mind doing the next slide, please, Mark. So you guys have probably heard of the Topol review. I did read a bit of it, or skim read it from my interview, which was a year or so ago. The next thing on the block now is something called Phillips Ives, which is going to be a review, and we are looking, there's a digital element to it. And guess what? I hopped on because I thought I had something to say now. And this is what has come from the Phillips Ives review so far. This is what they are feeling that nurses need to think about. So this is the Chief Nursing Information Officer's vision. So I really like that. So I wanted to share that. I think that's a positive thing. Next slide, please, Mark. That's the questions they're addressing from the nursing element. So I thought that was useful for you all to know. And if you've seen it all before, I'm really sorry, but I suspect you haven't, because not all of you were on the review. So you know what questions are being asked of the review. And I think if you, in your various regions, those of you that are nurses, find out who is informing the Phillips Ives review, and then they can funnel things backwards and forwards to you. 2 more slides. Next one, please, Mark. So this is their key themes. Nurses love key themes. They love pictures. But actually, I think these are really important key themes. And you can see, for me, it's a marriage made of heaven. We've got genomics and data science all going together. So I'm in heaven. And I will bring back an update, Mark and the team, and keep you updated on what's happening in the Phillips Ives review. And equally, please use me as a conduit to go, hang on, Tracy, just tell them this, tell them that. And I'm really, really happy to do that, so we can work as a team. Last slide, please. That's what they've heard so far. It's only just started. I don't think you'll be surprised at any of the things that you are reading there. But please do use me or your local nurses, if you know that they're doing the review, to be a conduit to get our voice, the patient's voice, back to that review. And I think that's it.
Last slide.
Super.
Yes.
Thank you.
Fantastic. Tracy, thank you very much for that really exciting presentation. It's the Phillips Ives review. I'm looking forward to hearing more about that as well, and I'm looking forward to hearing the results of that. Now, I'll put these slides up. I'll talk about them a little bit, but they're for people that want to get their phones out and use the another QR code for another conference. We'll talk about that. But Rob, you've got your hand up. Do you want to fire away with your question or questions?
Yes, I thought I could kick some questions off if you like. So as a kidney patient with access to my own results reporting, which I love, I wonder what people think about that. We've heard already that is it right for all patients or not, and how do you give options and explain the risks perhaps to patients of what they might discover? Because if I had a blood test and suddenly my kidney function was down at 10%, I mean, I'd probably realise because I wouldn't be feeling great, but it could be a massive shock. And similarly, if you give people access to all their results through the NHS app, and I get a result that tells me I've got cancer, and it's the first I hear of it, I'm going to be massively shocked and start worrying, and it might be something I that can be treated and I might not need to worry about. So I do think there are some risks around giving people direct access to results. One of the things I wonder if we should think about is using some AI with some of these tools so that we can decide what results go out. But also as a patient, my normal range for my blood test results is probably fairly unique to me, and it will be slightly different for someone else. And it would be nice, instead of having generic ranges, which Patient View is a fantastic app, and it does tell you about your blood tests, and it does tell you what a normal range is. But if a normal range for Rob is not the same as it is for someone else, it would be fantastic if we had some AI that understood what's Rob's normal range that we're happy with, and what are the outliers, at which point we start getting worried. But then I was thinking, I'd like that, and it'd be useful, but maybe that then worries patients. So you could use the AI perhaps to alert the consultant to make a proactive call to the patient if the results are out of range. And then I keep thinking about this more and more, and then I think, no, people get too many alerts already, don't they? And then we'll get alert fatigue because we'll start telling consultants a load of stuff, and actually what they need is the consultant appointment with the patient to go through the results a few weeks later. But I'm kind of interested in other people's views on it, because as a patient, I love having access to my results, but I'm able, because I know people in the NHS, or because I'm technically competent to do enough research to understand them. I'm not sure if we understand what the risks are around patients who it wouldn't be suitable for, and maybe those patients just never look at the results even if they're given access. I don't know.
That's a great question, and if I may direct that to Paul, I think we was talking about it last night, Paul, weren't we? But probably everyone else here wants to hear your views on that, if that's okay.
So I probably should have mentioned earlier. So one of the safeguards that has been designed in this is that actually results will not be available to patients or letters until they have been seen by a member of staff in the GP practice and saved and filed into the system. So there is an opportunity at that point there. By default, those items will all be shared, but there is a point in our clinical systems, I can untick a box and say, actually, this letter shouldn't be visible to the patient. And that might be ever, or that might be until we've had a chance to talk face to face. So there's definitely something about making sure that things have, don't have, surprises and unexpected things in there. The other thing that certainly with the results, what we do as a GP is when I file a result, I usually put a comment on there saying, as expected, or, mildly raised but normal for Rob. And those comments that give that context would also be visible to the patient when they go onto the online app. There's definitely some people I think should never see them. There are people who may find it distressing, or they don't want to. There's also an element about people who we think might be in perhaps unhealthy relationships, or their phone isn't private necessarily, so they may choose to not have access turned on for them. But I think to the last part of Rob's question, could this be better? Could this be more nuanced? Absolutely. Is there something here about AI? One of the things we do know, Rob and I both learned on the Digital Academy about alert fatigue and how crude some of our healthcare systems are compared to some other industries. I get the same sort of level of alert when I give you 2 blood pressure medicines, because it says, these 2 in combination, might affect blood pressure. And 9 times out of 10, that's intentional and deliberate. But I get the same alert from that as I do if I try to prescribe you a once-a-week drug every day, which, if I were to go ahead and do that, has a very high likelihood of actually being fatal. So our alerting could be better, could be richer. Last comment just on the kidneys, for those who may not be aware, but there's a commonly used slide when we teach medical students. If you look at the rugby league players who are playing in the World Cup at the moment and compare their kidney blood test results with little old ladies in their 80s and their 90s, you'll find very similar results because of the way their muscle mass is different. clearly one is a young man in the height of his fitness, and the other is somebody who's got very little kidney function left because of old age. So actually, could our computers be better and give us more context, more nuance? Absolutely. Do we have them today? No, not yet, but I'm waiting for it to come.
Thank you very much for that, Paul. I'm going to try and get through as many questions as we can.
I think this has been very helpful. I mean, one of the things that we see, because we have a patient portal that people can access, we have a block on histology and radiology for about a month after the report is through. So it's really trying to make sure that they don't get the surprises within it. One of the things I find about histology-wise is I sometimes struggle to actually, understand what the report means, and I can go back to a histopathologist and can kind of say, "Can you put it in English, please?" And usually, if I'm sending out a letter to a patient, I will say, explain a bit like you were talking about. This is normal. This is whatever else it is, and interestingly, in the United States, one of the biggest kind of gripes that the clinicians are having is how much time they are spending, answering queries. Say, for example, for a long time, our globulins were always high, just whatever way that the range was within the trust. And one of the issues with that is patients were asking, "Oh, my globulins are high," and they Google it and then think they're having real problems. So I think if we are going to do this, we should do a proper assessment of actually how much clinician time it takes to answer the queries. And that, because if you ask a clinician, they say, "Oh, it doesn't take long," but that's kind of not the question we're asking. It's how much time does it take? But I think certainly it has been of great benefit for patients having access to their results, but it's just with some of those more textual results, I think it's more difficult to understand. So we need to figure out how we actually change our workforce to be able to answer the queries.
Does Joe, Paul, Tracy want to comment on that?
I'd agree with that in terms of one of the points I made about our clinicians ready, and I think this does kind of bring in a change in how they work. So yeah, I definitely think that's part of it. That's why you need to look at the whole system, not just we'll give everyone access to results. What does that actually mean for patients, and what does that mean for clinicians? So yeah, I'd completely agree.
And so, I think you need to ask a clinician how long does it take, rather than just say it doesn't take too long. Actually, you need somebody who's nerdy enough to actually say, "Well, I will time how long this takes."
So I would say, and I don't work for NHS England, so I'm not being paid to say this, but they have done some pilots with the patient access to records, to GP records, and in the pilots they found that actually it hasn't led to a big deluge of queries. Their prediction is that actually this will overall save time, because the number of queries created by people saying, "Oh, what does this mean?" is lower than the number of queries that disappear. Because you've got to remember, at the moment, many GP practices will bring you in for your routine blood test, be that for your diabetes, your heart disease, whatever, and they are then encouraging patients to phone to talk to reception to get their results. So actually, by removing a lot of those transactional calls that are just for reassurance, yes, everything's fine, the doctor has seen it and said no changes. If we can remove 5%, 10%, 50% of those, what capacity does that create for people who want to get through on the phone for another reason, or they do find a query, or they find an error that they want to raise? So we think it will be a net benefit. I guess we find out shortly.
I mean, I think that was what the original thing was in the United States, but now in the last few years, I think probably because maybe more patients are accessing them, it's becoming a different kind of thing. So I suppose what I'd urge you in looking at it is look at it in 2 years' time and in 3 years' time, and see if it makes a difference, because it has taken that length of time to actually get the kind of intelligence in the US.
I think that's very true. I think we will enable this next month. As with any adoption curve, colleagues on this call will have seen that graph many times. The people who will be the citizens who will be going on and looking are probably those who've already accessed it, have opted in while it was an opt-in process. It will probably be 18 months, 2 years before we have significant numbers of the public using this and looking at it. And so, yes, I think you're absolutely right to review it repeatedly over time and not think, that was fine, nothing went wrong in week 2, right, close the project. I think that could be premature.
Thank you very much. Now, Jennifer, it sounds like your computer's unfrozen. Do you want to unmute and ask away?
Yeah, I actually have 3 questions, one for each person. I don't know if that's allowed, but I think there might be some quick ones. First of all, for Paul, the NHS app, you actually need a mobile phone to be able to sign on to it. Has that been fixed yet? I've gone up as high as I could in NHS Digital with a formal complaint about this, that you needed to have a mobile phone or smartphone.
Yes, there is a web version available now. It's not as fully featured as the mobile, but you can do it from a browser.
But to sign on to it, this was always the problem. There was a web browser version, but to sign on to the web browser version, you still needed to go through the portal that asked for a mobile phone number, and it wouldn't accept a landline phone number. I just wondered if that's been fixed.
No, that I wasn't aware of. That's an illogical restriction.
Yeah, I've been pushing for this one for ages, and I just don't seem to get anywhere. Just 2 other quick things. Tracy, I wondered if you've been working with local authorities. I was at a National Voices conference last year, and a lot of the local authorities were trying to get people and devices together for improving medical things. And I just wondered if you'd had any links up, because yeah, it seems like everybody's in their own stovepipes. I like that. I usually call it silos, but stovepipes is wonderful, Joe.
Yes, good point. And we have, and when I say we, that was actually the Macmillan team getting into contact with a group called Spark in the West Country where I am. So that was the beauty of having Macmillan, where they've got a greater reach. So it's holding hands with every agency you can rather than this silo stuff. So yeah, we have.
Brilliant. Joe, fantastic presentation. How do we change the balance and get the patient voice out there?
We're fighting. We've got a good patient voice swag, so we're trying to expand that. But it's just about patients shouting as much as possible and hoping that people listen. We get traction in the Cancer Alliance, which is good. People are listening to us. But it's just keep fighting.
Yeah, I know that the trust, the Community Hospital Trust in Gloucestershire has a really strong expert by experience program, and I keep trying to bring digital into that, but nobody from digital ever attends any of our meetings or talks to us. It's really frustrating.
All right, fantastic. Thank you so much, everyone. I'll just draw this to a close. So before we go, I would kindly ask you all to hopefully sign up for the conference, Let's Talk Digital. We did one this year, had 170 people sign up for that, 60 people in person, 70 people online, a hybrid event. We're doing it again. We're going to do it every year. It's a fantastic place to meet other people, like-minded people, talk over tea, coffee, lunch, and collaborate and make digital innovation just happen better at the front line. Having patients, representatives, our digital expert patients, our digital teams, our colleagues who want digital to happen there as well. And if you use the QR code there or the link I put in the chat, please sign up. I can see 4 of you have already signed up. That's fantastic. We're also going to do another quarterly meeting sometime in March, I think. I haven't decided exact date, but I'll let everyone know about that. Thank you very much, everyone, for joining. It's been a fantastic turnout, fantastic questions, and hopefully we can keep the passion and the dialogue about digital innovation at the front line happening. So thank you very much.